Oops, muting. Uh, Good morning or afternoon, wherever you are. Welcome. And we want to say that as Ms. Hassinger and I talked today, that we will have photos that are property of Ms. Hassinger, and those are HIPAA consented. We want to talk about the challenges that families have been facing during the pandemic. Next slide, please, Amy. And we have nothing to disclose. Next slide, please. Do want to say, as is everyone these days, that the information with COVID-19 and SARS-CoV-2 is changing every day. So what we say today is accurate for today. Our presentation today is based on an article that we wrote together about the early experience of families with children with medical complexity during the first part and early parts of the SARS-CoV-2 lockdown. That article, in fact, Rishi is the editor of the journal in which that is placed. So Rishi maybe will put that link in the chat box because it has been published. And we want to talk about those things today. Next slide, please. Our objectives are to encourage us all to learn about the challenges that our families have been facing, and from a wide array of families who faced unique settings, and to learn about that and to use that information to preemptively plan and identify solutions to address the challenges and the threats that these families face, and of course, help avoid them in the future. Next slide, please. So we know that the care system for kids with medical complexity is not slick and beautiful, even pre-pandemic. We know that almost 6% of children who are insured by Medicaid and CHIP represent our children with medical complexity. This is Dr. Bergman's work through the CARE Award. We know that these families run outpatient intensive care units. And with that sort of life at home, they have more exposures with multiple community and family members, friends, home care nursing, therapists. And so Angie's going to tell us about that today and how that is magnified by the infectious risk of the pandemic. We know that emergency preparedness planning is only variably performed across healthcare settings. And most of us had planned for, in North Carolina, we planned for hurricanes. In the Midwest, we planned for tornadoes. But we really had not sort of said, oh yeah, we got to think about a pandemic. Although Ed Fennell posted an article this week that was put together in 2015 about pandemic planning for the flu in New York, which I found the article really very prescient. We know our families did this work behind closed doors. They did not have the supports they usually had. And Angie will delineate that fully. Next slide, please. So we feel like it's important to hear from families to be able to address the uniqueness of these challenges that families have already transcended, but also things that may be ongoing or in the future. We want to highlight the expertise of the parents in reporting what's gone on because we weren't there as the physicians or the nurses. We just weren't there. And we need to underscore the importance of connection for the families, whether it be a trusted connection with a home health nurse or with a school teacher or with their formal healthcare system, and certainly to use that information from the families to prompt more investigation into situations where children with medical complexity had multiple threats, whether it be racism or climate crisis or fires, immigrant status, profound poverty, but we need to hear from a lot of families. Next slide, please. The Family Voices group prompted us to think about writing this article because they had been listening to their leaders across the country, and their leaders were hearing from person A and person B and person C reporting problems that the families were identifying. Interestingly enough, when we coded the narratives from the recordings of what the leaders of Family Voices were hearing, we were able to code these into different buckets. And this slide and the following slide really identify the things that people over and over and over again kept identifying as problems. You can read, Angie will summarize a lot of these, but we know that initially care gaps in home health services, supplies and equipment was a huge issue. Certainly communication about what is the truth about COVID was a big challenge. We know that telehealth rose up like a phoenix, and that's great. We need to keep figuring out how to use that. But as the pandemic pressed on, we know that mental and behavioral health challenges were striking. Schools were interrupted, therapies were interrupted. Next slide, please, Amy. And we'll hear from Angie today about the advocacy issues. The last 6 that are listed from the Family Voices group speak again to the fact that just hearing from 1 or 2 or 10 parents is not enough. We need to hear from people who've had a wide array of experience and can talk about all these other things. So with that said, I want you to hear from Angie because she has lived experience. Thank you, Angie. Next slide, Amy.
So I wanted to begin by introducing you to my daughter, Abigail Grace. So I'll describe the pictures. So the first is Abby when she was several months old, wearing a little gown my mom had made for her dedication. And the next is in the purple dress at age 2. So she sat still the whole time for the 30-minute photo shoot. The rabbits were changed out 2 or 3 times. And then the next is Abby in the hospital following her accident, a near drowning when she was 3. And then the final is just a handful of years ago, my husband, my daughter, and myself with Abigail at a Kid Again Christmas party. And so basically Abby, she was born perfect. She nearly drowned when she was 3 on February 29th, 2008. We're grateful it's a leap year since we don't have to have the anniversary of her accident each year. She was underwater for 30 minutes. When she was rescued, the AED would not shock her. She had no breathing or heart rate. She was ambulanced to Children's, and I think it was more than 20 providers working on her for a solid 2 hours before we had a pulse. So Abby's a miracle. She was in a coma for 4 weeks, in the hospital for several months before she came home, and she has healed very much from her initial accident, but is definitely not that perfect, healthy child she was at the beginning. She's completely dependent on caregivers for all of her needs each day. And if we go to the next slide, I could show you her bedroom, and that might help us to understand some of her needs. So Abby, she is 16. She is about 90 pounds. She doesn't move on her own aside from some controlled spasticity, maybe shaking her head if she doesn't want you to kiss her cheeks, or, pushing her arms kind of down her stomach, her abdomen if she doesn't want you to do her G-tube care. She has an oxygen condenser there, as well as tanks for portable, and then the large tank if we lose power. She's not on it continuously, but needs it as needed a lot of times at night or when she's sick. She has a tracheotomy and a G-tube. So we have a feeding pump, and then we have portable and stationary suction machines, a Hoyer lift, a pulse oximeter we use continuously to monitor her oxygen saturations and her heart rate, as well as just several supplies. There's a closet with medications, which I'll show you her med board later. She has more than 15 routinely scheduled meds and then as needed meds. And then she's also nonverbal and blinks to communicate her preferences and likes. So next slide, please. So the first challenge I wanted to discuss is gaps in home health care. Abby qualifies for 2 shifts a day through Medicaid waiver. Even before COVID, it was sometimes difficult to fill these shifts, especially on evenings and weekends. At that time, even before COVID, I would worry that if shifts were left open for too long, that maybe Medicaid would say, wow, this family's doing great without the help, and we may have a decrease in our hours. I also have anxiety each year when it comes time for her annual review. They come in and they use a point system to determine how many hours you qualify for. And basically they'll ask you things like, how many seizures does she have in a day? Or how often do you suction her in a day? Or how many times did you visit the ER or become admitted to the hospital this year? So we, of course, try to control the seizures and keep her healthy and definitely keep her out of the hospital. So I worry each year that if we do a really great job in her care and she's too healthy, she might lose hours because she has excellent care. Of course, COVID only made that more challenging, which I'll discuss more a little bit later, the issue of having, pardon me, home care. That is not needed. There we go. Not my dad, sorry. Okay, and so with the challenges in providing getting home care hours filled, I decided to go back to school about 5 years ago to become a nurse when I learned that parents could be paid to provide care for their children. And so I work the evening shifts and weekend shifts that are still challenging to fill. One of the things that I faced that was kind of difficult after becoming a nurse was getting my first job. A handful of the agencies that I first interviewed with told me, we can hire you because you have no nursing experience, which was very odd to me because I'd been doing the same things, providing the same care that their nurses would provide. And in fact, many times when nurses would come to the home, they wouldn't be capable of providing all of her care. And so I would provide training to these nurses. So that leads me to my next point, nurse training. So over the years, only a handful have come completely qualified to provide her care. So this prompted me to spend some time writing up a training checklist cheat sheet for new hires. When someone new comes into the home, I just plan to spend the first couple of days kind of side by side training them. And I usually won't leave the home for about a week. I ask them to do hands-on demonstrations of different parts of her care, like how, show me how to do a trach change or show me how to change a G-tube if that should come out. The challenge is, many of them can provide the basic routine care like suctioning or applying oxygen, but if they need to know what to do if there's an emergency and how to assess and determine, what to do next. So for example, if Abby were to DSAT, they first need to determine, well, is that a true DSAT? Is the oximeter reading correctly? And so maybe they just need to change the oxy tip or reposition. Or maybe they need to suction or apply oxygen or listen to her lungs and do a breathing treatment. Or maybe they do need to call an ambulance, but it's very important for them to be able to competently assess that quickly and not overreact or underreact in a given situation. And this is, of course, amplified by the challenge that Abby is nonverbal. So she can't communicate her needs to her providers. And then, of course, when the mandates for quarantine and school closures began, my day shift nurse had to stop working with us in order to be home with her family. Her children were now home from school on home education, and her youngest was no longer able to go to daycare. And so it took me a long time to hire another nurse. At first, maybe for the first several weeks of having that gap, I kind of felt like maybe it was a blessing, maybe one less person in the home who could expose Abby to COVID, but it just wasn't sustainable in the long term. I was working the 118 official hours as well as just, her 24-hour care. In September, we were able to hire a nurse who actually was very well trained to care for Abby and was willing to go to school with Abby, and we were very blessed. Things went pretty well. We did have a bump in the road around December 10th when both of the teachers in Abby's classroom tested positive for COVID. And fortunately, Abby and her nurse did not, but that gave me kind of a little scare. And we did send her back after an extended Christmas break, and she's back in school now, and COVID seems to have left the building. Next slide, please. So the next challenge I wanted to discuss is disruption of education and therapy services. For many years, I home educated all three of my children. It was much easier when they were younger to just include Abby with what the boys were doing. We did a lot of hands-on fun school. But as the boys have gotten older, they're 8th and 9th grade now, it's become more difficult. I don't really know how to include Abby in Algebra 1. So I decided that I wanted to focus on the boys' education and send Abby back to school. And there were many reasons. So she attends Rost, our county DDS school. They have a large supply of communication and technology devices that I don't have readily available at home. They're expensive, so they can try several devices and determine which one is going to be a good fit for her. She's currently using a squeeze switch to activate devices and make choices. This process would be really expensive at home and time consuming to have to purchase a device, send for it in the mail, determine it did or did not work. And they have technology that I don't, that they can use at school so she doesn't become bored. Her favorite right now is there's a leaf blower they have attached to her squeeze switch that she can activate to shoot a basketball in gym class, which I think is pretty cool. They also have therapists available at school, which saves us from making extra visits into the community. And it provides, she can have, more frequent therapies. They can also do basic things like, modify a hand splint, modify the wheelchair right at school. School provides socialization. I noticed that even for Abby, when school closed due to COVID, her whole sleep schedule was disrupted. She would be up late into the night. She would sleep all day. She was almost kind of depressed. When school started, I noticed that she was wide awake by 10:30 when she got on the bus. She stayed awake most often, through the day. Her nurse and her teachers told me, she was alert. And then she would take a nap when she got home and go to bed at a decent time. And of course, the issue of respite. Even at home, I definitely appreciate having the nurse come in and giving me a break from her care. But it's kind of a double-edged sword. I love having a break from Abby's care, but having the nurse come in, if we've had a movie night and the living room's trashed and there's, popcorn bags on the floor and the dishes haven't been done, I feel like I need to get up and hurry up and clean up like I have a guest coming in every morning. And that feels stressful. And I feel like with teenagers, if I need to raise my voice to get them to do their math today, I feel like I'm being judged as a parent. I feel like I can't just naturally function and be me in my house. And so being able to send Abby to school provides me a respite from her care, but it also allows me not to have somebody in my house constantly. Next slide, please. Another challenge is the challenge of wearing too many hats or mental health. So I know that this probably is something that resonates with all of you as well. So some of the hats I wear are, I'm a teacher, I'm a nurse, I'm a chef, I do the housework, I do the accounting, I'm a mom, I try to have balance, and I want my boys to grow up having the benefit that really can just be caught, not taught, of being raised with a sister with unique needs like Abby. But I also don't want them to resent her and feel like they grew up unable to do many things that normal teenage boys would be able to do. So that requires balance and a lot of effort. And in addition, right now I'm caring for my father who has cancer, and I'm in Ohio, he's in Minnesota. So that also adds, challenges. I know some of you are probably caring for aging parents and it's difficult. Let's see. So yeah, teenagers. I'm sure many of you guys have been through that too. Like with COVID and pandemic, raising teenagers, it's challenging at best. I understand that it's normal for them to want to push on the boundaries and become their, become who they are and to break away from us as parents and to challenge authority. But, when you add pandemic and all of the emotions and all of the loss that they're experiencing, no camp, no ninja classes, no being with friends, it kind of heightens the thing. And when I don't get respite, since I'm kind of the main glue in the family to kind of keep everybody together emotionally, if I don't have anything left in my cup to pour into theirs, that becomes challenging too. We don't have family in state. Our family is a 12-hour drive if you're driving really fast and not stopping. And so we don't really get respite in that manner. And as far as getting out of the house to get respite myself, with everything being closed, it's challenging to leave and to leave the things that are in the house behind. So, if I try to take a break, I still see everything that's going on here that needs done. So it's hard to just actually get a good rest. Next slide, please. Another challenge is the shortage of medical supplies. So we had worked with Walgreens Pharmacy from the time of Abby's accident when she was 3 to when she was 15, just as COVID was becoming an issue. And then this picture here is Abby's med board, and those are her routinely scheduled medications, not her as needed. So we knew the staff by name at Walgreens, and we had figured out how to navigate all of the insurance denials. A common denial for us is her liquid medications, which are much more expensive than her tablet form medications. Since she has a G-tube, she can't take anything by mouth, so they need to be liquid, and insurance would deny them. And working with Walgreens, it was one less phone call I had to receive and be involved in. They knew how to navigate that without me. So right around the time COVID struck, we received a letter from our insurance company informing us that we could no longer use Walgreens Pharmacy. We were given 2 options, the mail order pharmacy, which didn't seem like a good idea to me, or CVS. I did try to communicate with supervisor after supervisor and climb that chain of command to get a concession, because continuity of care is very important for children like Abigail, but I was not able to get any change. So we did transfer over to CVS, and we've had a lot of fun trying to work together and learn how to navigate those nuances and allowances with the insurance company. In addition, we had one of her seizure medications was having a manufacturing delay, the Onfi. And so whenever I needed to fill that monthly, we would have to take the time to contact each pharmacy and figure out which particular CVS had the medication available. And sometimes I would have to go to more than one pharmacy to fill the script. We were pretty fortunate with regard to her equipment and supplies. We didn't really have any problems getting any of her equipment, but what we did run into was a change in their policy for delivery. They no longer were allowed to come into the home. They would deliver to the front step. But the challenge here was that they would not let you know when they were coming, as in what day or what time of day. So we may come home to find supplies waiting in the rain or to find formula sitting in the sun. We live in a pretty good, safe neighborhood, so I don't worry about theft, but I can imagine some neighborhoods leaving supplies or boxes outside, they may disappear. Or, you know, if we lived in an apartment or a place with steps, having to carry all of those things up the stairs would be a challenge. So I'm grateful that we live in a home where that's not a challenge for us. Regarding personal protective equipment, I didn't really ask specifically with the equipment supply company, so I'm unsure if they would have provided additional equipment. They did continue to supply the gloves they had always supplied each month. For nursing agencies, I have 3 in my home. 2 of the 3 did not address the issue, but one has been very good. They've contacted family and staff on a monthly basis via phone or email to let us know that they do have supplies available in the office, and they are also willing either to deliver or have you pick them up. And these include things like gloves, masks, gowns, hand sanitizer, and you know, at the beginning of COVID, they even made handmade masks for all of their caregivers, which was very thoughtful. Each of my home care agencies has required a written emergency plan. So in Ohio, we focused mostly on tornado and fire. And so, you know, we have an under the stairs room, and the boys know how to empty it very quickly. We know how to get Abby in there. We've done practice drills. We have flashlights and a radio and some things in there so that we could be in there for a period of time safely. We've practiced the fire drill. We know where to meet. We have determined the minimum amount of things we need to get Abby out of the house safely, which is just Abby in her wheelchair with a blanket thrown over her and her portable suction and charger. We have a backup charger in the van, and Children's is 20 minutes away. So we have all of those things down. I think the biggest challenge for us is the caregiver situation. So if something were to happen to both Richard and I at the same time, I think our nurse would probably step in temporarily, but we don't have any caregiver backup plan aside from he and I. So if something were to happen where Richard and myself could not care for Abby, she'd probably have to go to a facility. And, you know, I hate to say I haven't seen one that I think would provide adequate care for her. I think her care would go downhill in that situation. We have people lined up that would help care for our children, but they're not willing or able to commit to meeting Abby's physical needs. They would advocate for her and communicate with the doctors for her. And there's even money not in her name set aside to help care for her. But, you know, for Abby, there's just not another backup care option. Next slide, please. Another challenge is health system access and telehealth. So when, back here, all right. At the start of COVID, we avoided hospitals and doctors' offices pretty much across the board for the entire family. It felt like the most likely place to contract COVID. I contacted my daughter's physicians via MyChart, which is a lovely tool. Most of them we see only once or twice a year. I asked them to put in all of her labs, and I found out when the lab opened, which was 8:30. We were there at 8:30. We were out by 8:45, and I set up telehealth visits. And that's been a wonderful thing. For me, I feel like If a visit only requires a review of labs and a set of vital signs and discussion, those can be conducted via telehealth. This may vary though, depending on the competency of the caregiver and the level of trust between the caregiver and provider. But we did have one visit we were going to conduct over telehealth that we decided last minute to bring into the hospital. Abby has an annual routine trach scope and bronchoscopy. And because they've always come back normal, we were going to skip it. We decided to do it. And I was really grateful we did because, as I mentioned, she's 16. She's grown. They needed to increase her trach size. And we wouldn't have known that if we had conducted the visit over telehealth. Next slide, please. And so finally, the importance of the parent partnership and patient advocacy. When Abby had her accident back in 2008, I was introduced to the complex care clinic. They managed all of the aspects of her care, so we didn't have to spend so much time visiting multiple specialties. We would consult with them when necessary, but we always stayed within the Cincinnati Children's Hospital network, which was very helpful when there was an emergency to have all of her information in one place. It was also nice to be in a practice who knew us so that I didn't always have to start over at the beginning each time we had an appointment or each time we had a sick visit. I didn't have to start with, well, Abby was, a healthy child who didn't have any issues, who nearly drowned at age 3, because that's kind of emotionally taxing to have to run through each time. They helped me before we left the hospital after her accident with applying for Medicaid, making sure we had a medical supply company, home nursing. Having a one-stop shop that provides total patient care for kids like these or for anybody is really invaluable. These physicians encouraged me to learn how to advocate for my daughter. If you guys know the name Ron Levin, you should know what I'm talking about. It was intimidating, but really helpful. Decisions were made jointly between us, in contrast to the old paternalistic model of doctor knows best. Parents need to be encouraged to advocate for their children. They are the experts in their children's care, and the physician is the expert in medicine, and both are needed. But trust takes time to build. And my concern is that those in certain demographics may feel too intimidated to speak up. They may be afraid to admit they aren't comfortable with a certain procedure. For example, I did foster care for several years, and one of my placements was an infant who had an NG tube. And when the mom was at the hospital, before she left, they had explained to her that you needed to check placement before you gave medication or food, because if the NG tube was in the lungs, then you could it could result in death. And so she did want to understand how to do it, but she found it very difficult to learn how to hear that subtle hiss of air that says that, you're in the right place. And so she was afraid to continue to say, I don't understand how to do this. And so she brought the child home. And then she just didn't give her any food or medication, which seems ridiculous, but she understood the risk of doing it wrong. And so the child came into placement, but this wasn't a mom who set out to hurt her daughter or didn't love her daughter, but she was afraid to speak up. Or you may have a family who is unwilling to admit that 2 a.m. is just never going to work to give a seizure medication. So when they come in to their appointment, they're saying, well, the child's seizures are increased, and so the physician increases medications or adds new medications on when really they just need to, change the dosage and times. I also wanted to take a moment and touch on the challenge of disability rights and rationing of care. I was super excited to learn that this has been discussed by Family Voices. I'm relieved to learn that the parent at the bedside issue has been addressed. Even for adults with complex medical needs, this is so important. It is scary when you consider limited resources and you have a handicapped child and you feel like they may not be chosen over a typically healthy child if a choice has to be made. I was made aware recently that some places like New Mexico and New York City have already authorized crisis standards of care, which opens the door to this rationing. And frankly, I find it terrifying. Thank you for allowing me to share my story. I'm blessed to be able to see good come of what has been a challenging situation that we never could have foreseen. I feel very fortunate to have safe housing and consistent employment with good benefits, a healthy family, a good education, and the ability to provide a good education for my children, a solid marriage, I can't begin to imagine how much more difficult caring for a child like Abby would be if I didn't have these things. I understand that many families face stressors that I don't, and I hope that these discussions will continue to assist in finding ways to improve the outcome for these families. Back to you.
Next slide, please, Amy. I always have to take a breath when I hear Angie speak. What can we do with this, with all these issues that Angie's raised? We know there are many more, but we as clinicians, as healthcare system workers, as social workers, as people in the community, with educators, we can learn more about the details of care disruption from a wide array of families. If I just look at the people across this list of folks who are here today, we have people all across the United States, and I'm sure that the challenges and different geographies are unique. We can partner with our community members, whether it be home health, whether it be the schools, to sort of figure out solutions and spread those even across states, and communicate and reach out with the families in a proactive way to say, hey, how are you doing? We know everybody's been locked down for a while. What do you need? What are you missing? It will be important to codify the emergency care planning processes. I practiced pediatrics for 40 years, and I cannot say I was 100% reliable in making sure that every family had an emergency care plan. We need to also work on our social determinants of health screening to highlight those things that Angie mentioned that could make pandemic care even more challenging. We certainly need to close our care gaps that have occurred, like the almost missed tracheostomy scope, and help people catch up with what's been left undone, and capture data to be able to inform our policymakers to say, this many kids had this much challenge, and certainly continue to address inequities that we know exist for our children with medical complexity. Certainly, some of the work I've done before is actually identifying populations so that when we need to do outreach, or hopefully, fingers crossed, when we have a vaccine, that we'll be able to know exactly who we need to find to be able to do those interventions. So thank you for working with us today. Look at the article, please, if you would. And Amy, I think that we're back to you. Here are references of the things that we discussed today.